Good morning, good afternoon, good evening, clinical problem solvers. So nice to see everyone today on this Tuesday morning in San Francisco. That may be afternoon or evening for some of you. And it's Neurology Morning Report. We're trying to do this about one Tuesday a month. And we have one of our star UCSF neurology residents, Ori Lieberman, who is going to present a case. So I hope everyone has 2 to 3 hours for VMR this morning, because Ori likes to stump the living daylights out of me with tough cases from his experience here at UCSF. And we would love to have 2 people to discuss Ori's case with Ori and me, ideally one identifying as a woman and one identifying as a man. Do we have some discussants who are hoping to discuss a case today? Joy, thank you for volunteering. I know you volunteered last time also, so we'll give others a chance just in case, but often we don't have too many volunteers, so happy to have you. Anyone who'd like to discuss a neurology case? Maybe you were thinking, oh, I thought it was medicine morning report. I wanted to discuss renal failure or hyponatremia. And oops, it's neurology morning report, but we would still love to have you discuss and hope you'll enjoy and learn along the way. Anyone? All right. Maybe, Ori, if you want to introduce yourself a little bit, and that might inspire some people to see how friendly you are and how much fun they would have discussing a case with you.
Sure. I'm Ori. I'm half losing my voice over here. But I'm a R2 neurology resident at UCSF. And this is a case that I had last month at UCSF. So it should be really fun to discuss.
Excellent. Thank you, Ori. Let's see who you've inspired here in the chat. Anyone? All right, Joy, you're in because no one else seems to be jumping in here. We would like one more discussant. Joy, why don't you introduce yourself so people see how nice it will be to discuss a case with the 3 of us.
Hi, so good to be back here and to see Dr. Berkowitz. I am applying actually this season for neurology. It's a little bit depressing because I'm not getting interviews yet.
Oh, I'm sorry.
But here in New York, I'm doing a lot of clinical rotations in neurology and some private practices around here. So yeah, a recent one was a large TBI practice. So yeah, I've been learning a lot of neuromuscular stuff and neuromuscular neurology. I realized I didn't know anything much. So yeah, that was very But
Great. All right. Well, we wish you luck and hope you'll start getting some interview invites soon. And anyone else like to discuss?
Yes, please.
Oh, great. Amanda, sure. Do you want to introduce yourself? Thank you for volunteering.
Hi, everyone. I am Amanda from Brazil, and I'm so excited and nervous because neurophobia, but I will try to discuss today, and I hope you enjoy and I learn from you.
Great. Thank you for volunteering. Wonderful to have you. And let's see if we can diminish your neurophobia today. Okay. Ori, would you like to give us the chief concern?
Sure. Confusion and weakness.
Confusion and weakness. Okay. Amanda, would you like to comment on either confusion or weakness or both together, as you like?
Okay, so with this chief complaint, confusion and weakness, I think like stroke or some disease cause the symptoms, and or just hypoglycemia can cause confusion, or Alzheimer's disease. I think in this way, this is hypothesis, but I want to know the time course, when starts, what happens if it's the age of the patient, I think like that.
Yeah, excellent. So you're right. We're going to learn a lot more in the HPI about the time course and the context of this patient, but you did what we call thinking fast, right? You hear confusion and and weakness together, and you think maybe if it was some type of sudden neurologic condition, it could be a stroke. If this is confusion that's been going on for years, it could be a neurodegenerative process like Alzheimer's that you mentioned. And you also mentioned that we have to always remember toxic, metabolic, or medical causes of any neurologic symptom, which you mentioned hypoglycemia, which could cause confusion and other neurologic symptoms as well. So great. So you're already starting to think about potential diagnoses that may or may not rise in our differential diagnosis depending on the time course and context here. Excellent. And Joy, do you want to tell us your approach to confusion or weakness or both symptoms together?
Yeah, I would want to like clarify what exactly do they mean by confusion? Like, what exactly is that kind of altered in mental status? I would like to understand more of what they mean by confusion. If it's like a problem with awareness, alertness, so we will have like sort of like where could be the possible, localization of what's going on as far as the brain, the cord, the whole awareness, like the whole reticular activating system, that the ascending reticular, where I'm going here, right?
Yeah.
Like that part of the whole part of awareness, alertness, and stuff like that.
Great. Yeah, great thoughts. So confusion, right, as you said, is very general, or people say altered mental status. What exactly do we mean by that? I'm sure we're going to learn a little more soon, maybe not necessarily from the patient, though maybe some patients can tell us they felt confused or otherwise, or maybe from Ori having spoken to family members or friends of this patient. But right, when we sort of zoom out and say there's some type of problem with thought, we want to know, as Joy was alluding to, is this a problem with the level of consciousness or with the content of consciousness? So level of consciousness meaning, is the patient difficult to arouse? And some people use these terms, stupor or somnolent. These can be sort of mean different things to different people sometimes. So it's helpful to say, just when you talk about the exam, as I'm sure we'll hear Ori do, the patient, had eyes closed but aroused to voice, or only aroused to deep noxious stimulation, or wasn't arousable at all. Are we talking about sort of level of consciousness or depth of impairment of consciousness all the way down to coma? And then if the patient is awake or can be brought to the awake state, then we talk about the content of consciousness. And is there a problem with attention, with memory, with language? Depending on where this case goes, we can go down any of those particular rabbit holes, right? But some people with aphasia, the first evaluation, someone will say they appear confused when actually it's just a language deficit, not just, but it's a language deficit appearing as confusion. Or I've seen patients who some people think are delirious, and as you sort of tease things apart, you realize they actually have amnesia, and their confusion is because they're not recording any new memories, and so the environment is constantly new, and amnesia is the actual a problem in the memory system is the lesion, right? So we're going to want to understand, is this level of consciousness, content of consciousness, and then we know that localizes to the brain, right? Or unless there is a medical sort of cause of altered mental status. And then within the brain, can we localize that, as Joy said, to somewhere along the reticular activating system for level of consciousness, from the sort of dorsal superior pons and midbrain to the bilateral thalami to the hemispheres. So we need bilateral or large unilateral or well-placed unilateral lesions to cause a globally depressed level of consciousness. And then we have weakness. Maybe until we learn, I know Ori's, if I know Ori, this case will have many twists and turns, so I don't want to use up all my time here, but just a few comments. We know if we're talking about weakness, one, we have to ask ourselves, is this a true diminution in strength, which would require some type of neurologic lesion, or a sort of asthenia, meaning that the patient sort of has the perception of weakness, but if you do test them, they do have their full 5 out of 5 strength, at least briefly. And we all know what this feels like, right? If you've had a bad cold, bad flu, COVID, you feel weak, right? You feel like it's harder to do the things that you want to do with your arms and legs. But if someone tested you and said, give me your best strength just for a second, go, 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 go. Okay, you do have full strength. You just feel sort of weak. And if we have true neurologic weakness, right, we have to be somewhere along the motor pathway from the precentral gyrus down through the subcortical white matter, corona radiata, internal capsule, anterior midbrain pons medulla, crossing over to the other side of the spinal cord and descending in the lateral corticospinal tracts, and then to the ventral roots, to the anterior horn cells out, the anterior horn cells out through the ventral roots, to the plexuses, to the peripheral nerves, to the neuromuscular junction, to muscle. So from the beginning here, if we say we have to have some lesion vertically along this pathway and some lesion horizontally along the brain, right, for the confusion, where do those things line up? Well, either we have to have multifocal lesions, right? Or if we are parsimonious and think of one lesion, presumably we have something in the brain causing both an altered mental state and weakness, or possibly something in the brain stem and causing altered mental status and weakness. Obviously, something in the spinal cord alone could cause weakness, but not confusion. And then below that, in the peripheral nervous system by itself could not cause confusion, right? So putting these two together in a Venn diagram, I'm not sure anything immediately comes to mind except sort of more playing the game of morning report of guess what complicated diagnosis Ori would bring to morning report. This isn't just going to be someone probably who's hypoglycemic. I'm remembering Maria's case of Bickerstaff encephalitis, where the patient had confusion was the main thing, and somewhere buried in the exam were decreased reflexes, and we sort of said, well, some patients have that. And then someone said, if we took out the altered mental status, couldn't this be Guillain-Barré? And I said, oh, it's Guillain-Barré, and it's altered mental status. Oh, it's Bickerstaff. So that's not, we couldn't get anything from these three words, but that's just sort of for fun, trying to put these together in some unique morning report kind of way. Okay, so Ori, when you went to see this patient, what did you find?
Okay, that was great. So this was a transfer in. So I'll tell you the initial HPI from the outside hospital. So she was a lady in her 50s. She had a past medical history, really only notable for bipolar disorder. And she essentially was getting weaker over the course of weeks, to the point where she became bedbound and then was refusing to go to the hospital. And a family member or friend essentially came over one day, and she was just completely confused and not making sense. Whereas it was the day before, she was totally normal, mental status wise, and he brought her into the hospital. And she had, I guess you want to stop there, or do you want to, I can go a little bit, I think maybe the next step would be to get to the, I think we could either stop here or go all the way to the exam. It's up to you, Aaron.
So this is the information you had, Ori, when you first saw the patient. I'm sure you had outside test labs for the purposes of, well, yeah. I'll leave it to you. If we want to do this as it evolved in real time and you had some data here that moved you in one direction or another when you first saw the patient, it's fine to reveal that, and we don't have to go in order. We can do the real life version. I defer to you because you know what's going to happen and I don't. If you want to stop here and do it as sort of all history, then all your exam, and then labs and imaging, I leave it to you what you think will be most educational and fun.
Let me tell you a little bit about the weakness. So it was a little bit unclear, but it sounded like it was much worse in the legs and the arms. And that essentially for a while she was feeling weak, and I think early in the course actually was having some gait instability, and presented to another outside hospital where they found her lithium levels were elevated and thought that she was lithium toxic, and then was discharged. And then her legs became progressively more weak. She couldn't walk. She then became bedbound. But she was still able to use her arms, and then eventually got to the point where she couldn't use her arms to feed herself, and actually had a pretty significant weight loss as well. And this was, so then we had ancillary data that I will tell you later. So maybe that's enough to go from there.
Perfect. So Ori gets a lot of these patients, right? San Francisco is actually not that big of a city, but has a huge catchment area up way up into Northern California, where there are very limited healthcare resources, and where apparently there was a big earthquake this morning. So patients are transferred in from very far away, and Ori gets a call that someone is coming from very far away, and a big stack of paper is going to come with them. So this is sort of interesting, where you actually get sort of someone else's history exam, labs, imaging, and what they were thinking, and then have to sort of decide what you're going to ask at the bedside. And I say all that to say, maybe for the next step, I'll ask you, Joy, just to, if you had all this information from the paperwork that came with the patient, and you're in Ori's shoes, as you soon will be, going to the emergency room to see the patient, what are some of the things you would want to clarify in the history to help you here, and why?
So I would definitely ask for like medical issues, you know, like are they having something already chronic going on, like hypertension, you know, hyperlipidemia, those stuff, and yeah, any sort of like chronic issues, health issues, and yes, I guess I would clarify what do they mean by this whole confusion and weakness, like more information about this from at least two sources, like collateral information, you know,
Yeah.
try to understand.
Yeah, very good. So right. So if I had all of this, I guess I'd, start to think about this as, relatively acute. Oh,
Like,
sorry. Go ahead.
I just thought, sorry, but like, is there anything like new to their medication, something like that? Because definitely, yeah, medication.
Yeah.
Confuse. Yeah.
Yeah. Excellent. Right. So we have something that's evolving over weeks in the extremities, and then something, so that's sort of in the acute to subacute window, and then something in the more acute window occurring to cause this confusion. And whether this is one process or two processes, we're going to have to figure out, right? Whether there's something going on causing weakness and then something new causing confusion, or whether one process has begun with weakness and then has also caused confusion. So I guess, or the direction of the case, but let me ask you this. You saw this much information, probably a little bit more, to be fair, and you were going to the bedside. What were the questions you had in your mind as you were starting to think about how you were going to sort this out at the bedside, in terms of just the history at this point, and then I'll add if I have anything.
Yeah, I mean, acutely, the scary things are, we get a lot of these like GBS referrals for an EMG. So, and that was the indication for referral, was for an EMG. And I think that the scary things are like neuromuscular weakness, and how severe is the weakness, and do we need to be worried about some sort of emergency? And then the second question is really trying to understand like the geographic pattern of this. Was it symmetric? Was it asymmetric? And then the domain, like cognitive domains that she was having this like what confusion meant essentially, which was not very clear to me at that point. Those were the things that I was thinking about. And then on exam, which we can talk. Do you want to? I think.
Yeah, let's pause there. Okay. Yeah, great. So that's great. Yeah, and I guess I would just say, right. So we want to figure out. Ori's thinking this patient is coming in from far away, and we don't know that much information. How sick are they? Right. This is very Ori, essentially the neurology intern is the second year, right? How sick is this patient? Are they landing on the floor and they should be in the ICU? And what are the things causing rapidly progressive weakness that could make them the sickest? And I was talking about neuromuscular causes such as Guillain-Barré, some type of myasthenic crisis, something like this. And so I think the questions I'd be wondering about, once we see the patient and decide, oh, this patient is really sick, and whatever they have, I need to do X, Y, and Z, which is sort of running through Ori's mind, is, okay, we have the arms and the legs affected together here. And so this is symmetric. Before the confusion, at least, we would have said to get bilateral, all four limbs, right? We're probably not in the brain if the patient's awake and talking to us. We're probably not in the brain stem if there's nothing going on above the neck. So we're in the spinal cord or below, right? So we're in the spinal cord, nerve roots, nerves, neuromuscular junction, or muscle. So one important question will be to ask about bowel and bladder, because if that is dysfunctional as well, we would be worried about spinal cord or cauda equina. Can't just be the cauda equina because we have the arms. So in this case, we'd be worried about something in the cord. And if the bowel and bladder are not involved and there's truly weakness in all four limbs severe enough to be bedbound, we're probably not in the spinal cord, right? So then we're in the periphery, and that really limits our differential quite a bit. What could cause rapidly progressive weakness of the arms and legs? That's not, an epidural abscess or transverse myelitis or something like this. It's sort of Guillain-Barré, more or less, although we could probably think of rarer causes at the neuromuscular junction or muscle. And then we heard about this lithium, right? We try to make some Venn diagrams with the patient's medical background. And Joy was asking also, what other medicines, what other diseases has Ori not revealed to us, or maybe are not even known yet to the patient, depending on how much medical care they've received. So yeah, lithium can cause tremor, which is quite common. So I would think if the patient was lithium toxic, we'd see that, although maybe now too weak to even tremble. But sort of confusion, tremor would be things that would make us think about the lithium. I don't know about diffuse weakness. I guess it's a 1+ cation, and so I don't know if it can mess around with neuromuscular transmission. Maybe Ori knows or learned that, or we're gonna learn that. No, Ori knows a lot of medicine, and so I'm not sure about that from the neurology perspective. I'd have to look it up. So that's what I'd be wondering here. Is there bowel and bladder? Is there back pain? And then, as Joy said, other things that would make us sort of have some contextual clues here. Was there a previous illness to make us think about Guillain-Barré? Is there intravenous drug use that could make us worried about an epidural abscess or endocarditis, and then seeding the spine and the brain later to get the confusion? But yeah, so I would want to know bowel and bladder, back pain, context, and then I think the exam. Yeah, so what happened when you, what's next, Ori? Do you have more history to reveal to us, or are we up to the exam from what you were going to present?
I can answer those couple history questions, and then I'll tell you the exam. So she did have bladder issues she was having urinary retention where she couldn't feel that her bladder was distended. So it was a little hard to put into. I mean, you think bowel bladder, you think cord, but it sounded more like a lower motor neuron bladder issue. And then let me tell you the exam.
So just hold on one second. Thanks.
Sure.
So let's come back to you, Amanda. It's been a little while. So you heard that there's bladder here. Does that help you think about where this might localize?
Yes, I think in the spinal cord, like doing a compression, and the patient couldn't feel the bladder. I think like that.
Yeah, excellent. So we think, I think it's helpful when you hear about sphincter dysfunction in neurology, right? Because there's lots of sphincter dysfunction that's not neurological, or I should say bowel and bladder issues that are not neurological. It's helpful. A lot of people say spinal cord, and I think it's always helpful to just say spine so that you remember spinal cord. And as Ori mentioned, cauda equina, right? Because the cauda equina is in the spinal column, but it's not the cord. And as Ori mentioned, the upper motor neuron compression of the cord itself first causes like the spinal shock, just as you get areflexia and flaccidity early on. So you can get a flaccid bladder that will then retain and then have overflow, and then chronically become spastic and can have urgency in those symptoms. Whereas if you have lower motor neuron dysfunction affecting the cauda equina, then you are inhibiting the sort of direct parasympathetic input that allows you to empty the bladder, and so you retain, right? So if you have in the acute setting retention, that would sound a little more cauda equina, although wouldn't obviously explain the arms. Okay, and then one more question for you, Amanda. If you're thinking about the spine, what are you going to be looking for here on the exam particularly? What are you listening for?
Maybe, I don't know how to say in English, areflexia.
Yeah, okay. Yeah, so the reflexes, yeah. And how will you use the reflexes? Yeah.
I don't know how to explain this, but Babinski and in the lower limb, and Babinski So in the patellar reflex and in the upper limb. So here I think there is a reflex too. I'm not sure if you understand, but
We understand perfectly, and your explanation is perfect. Yeah, so we're looking for whether the reflexes are hyperreflexic, so increased, and we're looking for whether there are pathologically present pathologic reflexes present, such as Babinski sign in the lower extremity or Hoffman sign in the hand, where you sort of hold the hand loose and flick the middle finger and see if the fingers and thumb flex together. It's important to note that with acute upper motor neuron lesions, so with a stroke or with spinal shock from, say, trauma or early and transverse myelitis or spinal cord infarct, the upper motor neuron signs are often not there. They take time to come out. So you've seen patients with a stroke, they have flaccid weakness, that spasticity you don't see till later. That being said, if this has truly been going on for weeks, probably too early for the patient to be spastic unless the time course is, the patient was maybe weaker for a longer time, and we don't know that always clearly on the history, but should be long enough to get Babinski's and hyperreflexia if we're affecting the cord. But if everything's absent and it's kind of acute, we don't always know if it's upper or lower motor neuron. So the reflexes are going to be key, as they often are. And then, of course, we haven't been talking much about the confusion, but we'll want to better understand what's going on there. Is it arousal problem or cognitive problem, or some of both? I think this is one where we're still, if this is all we know, that the patient has rapidly progressive weakness, even more rapidly progressive confusion and some urinary retention, we're starting to invoke that, at least in some way, probably the cauda equina is involved, but we're going to the exam relatively wide open, and hopefully there will be clues there that are going to help us. As we know from some of these cases in the past, right, we come to the exam and we sort of already have a really good sense of what we're looking for, and we're looking for sort of hypothesis confirming things on the exam that tell us we're going in the right direction, acknowledging that we may get surprises and have to revise. But here's one where, at least based on the history, we have a lot to learn from the exam that's going to help us localize both what this confusion is and where along the neuraxis the weakness is coming from. So what did you find at the bedside, Ori?
Okay. So her vitals were normal, except she was just like mildly tachycardic in the low hundreds. And her respiratory rate was like in the mid 20s, I would say. And she was like a little bit uncomfortable breathing wise. Her systemic exam, her lungs were clear. She was obese, no edema, otherwise normal. And then her mental status, so she was awake, interactive, alert, and oriented to herself, but she thought she was at a farm, and her speech was normal. She had no issues with naming or repetition, and then her attention was normal. But we asked her what she had done yesterday, and she said that she had rode a horse into the house. We also asked her if she saw a string, and she did, and described the string beautifully, even though there was no string.
Do you want to quickly explain that? Because that is, at least to my knowledge, a UCSF thing, or at least I haven't seen it anywhere else.
Oh, I thought that was a non-UCSF thing, but
maybe it is, and I've never seen it before. But either you or one of the other residents told me about it, and I said, "Oh, I've never heard of that test here."
So if you, so what we're testing for is confabulation, where if you say something that is obviously not there, they can confabulate about it and tell you a whole story about it. So if you say, "Oh, look at this string, what does it look like?" They'll say, "Oh, it's red and is a ribbon," and they can describe this whole thing, even though I'm not holding anything. The risk that Aaron and I have talked about is that they say they're actually normal, and they say, "What are you talking about?" and they think you're an idiot. But
I see.
So that we're testing for confabulation.
Yeah. Right. So sometimes you can just ask the patient, I'll ask, am I wearing glasses? And say, oh yeah, and they're very nice, glasses, this sort of confabulation, or, do I have a beard? These types of questions. What color is my shirt? And the patient will tell you a whole story with complete confidence. And you can, we won't talk about what that may signify, but yeah, this showing the string I think Ori implied, but didn't mention in case you can't see his video window there, there's no string.
Yeah.
You're just pretending to hold up as if you were holding up a string. Okay. Okay, so go ahead. Yeah.
Okay, the cranial nerves were normal. She had like pretty strong cheek puff. Her motor exam, so her bulk was normal. Her legs were flaccid. Her arms were also like had a little bit decreased tone. And then her legs were completely paralyzed or plegic. Her arms, her wrist extension was absent. She was anti-gravity at the elbow, but not at the shoulder. And she could kind of go like this. And then her neck flexion was full. And her reflexes were absent everywhere except the biceps. And her sensory exam. Sorry, my daughter just came in to say good morning. The sensory exam, she had decreased pinprick everywhere, absent pinprick everywhere except like on the upper chest and the face. Couldn't very hard to do cerebellar in the setting of this weakness, and then obviously no gait.
Ori, do you want to just explain why you flagged the neck flexion as something you wanted to discuss specifically?
Yeah, no, I guess the question is like when you see someone huffing and puffing, is there like kind of bulbar or concern for like respiratory muscle weakness, and neck flexion as like being a proximal muscle can kind of be a proxy for that.
Yeah, excellent. So when you're worried about neuromuscular weakness, right, we can't easily test the diaphragm, but neck flexion and neck extension are innervated by very high cervical roots, right? And so that can be sort of a proxy for the C345 of the diaphragm. So if we see a patient with neuromuscular weakness and we're worried, is this going in the wrong direction, severe Guillain-Barré or myasthenic crisis, then if these muscles are strong, we can have maybe some mild reassurance. And if they're weak, we are more worried. Another thing you can do, not sure if Ori did this, but have the patient take a big deep breath and count as high as they can on one breath. And every 10 they can count is about 1 liter of vital capacity.
Yeah, she got to like 22, I think, on that initial exam. So it was not robust. And then I forgot to say there was like no fatigability. Like she was able to sustain up gaze and all that stuff. Yeah.
Yeah, I was going to ask, her eye movements are normal. Yeah.
Her eye movements were normal. Yeah.
Okay. Got it. All right. Joy, what are you thinking after the exam? You can pick out one part of this and say how it helps you, or the whole thing in total and how it helps you, or however you like. Oh, I think you're muted, Joy.
So yeah, I was really thinking about assessment of their breathing, like the weakness here, the presentations kind of like leaning towards GBS. So yeah, I was curious about that neck flexion because you're if I understood you right, you were referring to C5, right? Like the phrenic nerve here that could have been compromised, but that's like yeah, just like towards that, at least that part, like the C5 part. But like I'm curious about how at least the accuracy of this because like with GBS you don't always, because it's a muscle problem, so you don't always see that low oxygenation in their blood, or at least the AA gradient doesn't would look normal, but like yeah, I think the vital capacities, those would help here, give us like a really good idea as far as their oxygenation. Yeah, because like they're tachycardic, so yeah, I was just like, that was like where my mind is going at first, but yeah, the rest of the exams are kind of like what we expect here. But I'm very I'm thinking if there's only the biceps reflex, this like the rest they did all the rest of the proximal and the distal reflexes were like gone. So this is a little bit severe at this point. So Yeah,
Yeah.
those are my first thoughts. So
Yeah, great. Right. So this patient is extremely weak and there's tachycardia and there's Maury's saying maybe some initial respiratory distress, all very concerning. And you made the important point that in our patients who have neuromuscular weakness as the cause of their breathing problems, the oxygen can be falsely reassuring, right? Because the problem is that they're retaining carbon dioxide. And so you can, if you say, oh, this patient I think looks okay because their O2 sat looks good, that's not going to go down until very late. So that's a very important practical clinical point.
from my rotation, I would say.
Yeah, that's a very important point. So Amanda, anything jump out here to you that you wanted to talk about? And then I can.
I'm okay.
You're okay. All right. So let me ask either of you, Joy or Amanda, let's just take the motor part of this. There is flaccid leg weakness. The arms are weak as well, though not as weak as the legs. There is absent pinprick and there are absent reflexes. Where are we localizing this problem? We had previously mentioned the spine and cauda equina. We mentioned the whole neuraxis in terms of brain, spinal cord, brain, brainstem, spinal cord, nerve roots, nerves, neuromuscular junction, and muscle. Any sense on the motor side where you'd like to put this?
Okay, so she's not speaking. Well, definitely lower motor neuron, like that whole strip towards peripheral nerve. So nerve root towards peripheral nerve, like different, the flaccid muscle, complete paralysis. If I'm understanding the exam here, at least the legs, the distal muscles. So yeah.
Yeah.
Mhm.
Excellent. Yeah. So we're seeing sensory and motor deficits and absent reflexes. And if we believe our history, I believe Ori's history, but sometimes the history itself is hard to obtain, especially if the patient thinks they were riding a horse yesterday. And clearly we're not riding a horse, then it's hard to know. If we believe the history, then we can say if it's been going on for this long and the reflexes are out, probably we are in the lower motor neurons, as Joy said, roots or nerves. And that you can get diminished reflexes in muscular disease, but the muscles have to be so weak that they can't generate the reflex. So the legs, we would, sort of be left with an ambiguous situation. But if she can move the arms anti-gravity and has enough strength to do that, and there should be enough strength to generate a reflex. So if those reflexes are out, we're in the root or the nerve. This doesn't explain the urinary retention. Usually that points us towards the spine, as I said, which could mean spinal cord or cauda equina, just because the nerves from the spine to the bladder are so short that a peripheral nerve process usually doesn't do this. But in this case, if this has been going on for weeks and Ori has collateral that's the case, then sometimes, as you've heard me say, it's helpful to take one element out and see if everything else adds up. And here I would maybe take the bladder out and try to connect the dots otherwise. So we have a rapidly progressive sensory motor neuropathy. Could this be an anterior cord syndrome? Also possible, right? Getting the lower motor neurons, the anterior horns, the anterolateral tracts for pain and temperature. And from top to bottom, when can you see that anterior cord syndrome with vascular lesions of the spinal cord? This has been going on for weeks. The strokes of the spinal cord can stutter a little bit and not sort of obey the sort of sudden rule that they tend to in the brain, and can take a few days maybe to complete themselves, and then people confuse them for transverse myelitis. And a very nice recent paper in the last few years showed that the most helpful predictor of the clinical diagnosis, underlying diagnosis for acute spinal cord pathology, is the time course, even with all the CSF and all this data distinguishing vascular from inflammatory, since these can be hard to distinguish on imaging, which is a great paper we can send around. So I guess this could be anterior cord also, and that would bring the urinary retention back in. Because he's told us the dorsal columns. Well, you didn't tell us the dorsal columns are spared. I don't know if you tested vibration proprioception, but
I did not actually.
So they may not be spared. So then we would not be in an anterior cord syndrome. You brought your string, but not your tuning fork.
I would say that she did have some joint position sense problems for sure.
Okay, that's helpful. Yeah. So we have tested that path. Okay, so we'll take that out. Right, it's either the whole cord. which is possible, but then the absent reflexes, Novobinsky put us back in the periphery and encourage us to remove the urinary retention, maybe at our peril. We'll have to figure that out. So we have a rapidly progressive neuropathy, and then we have to put this mental status back in. So what do we make of this mental status? We were sort of all thinking as we heard this patient is having trouble breathing and is weak, that maybe they were going to be somnolent and hypercarbic, and maybe that was going to be the explanation. At least I was thinking that. And then we hear actually awake, alert, the speech is okay, the attention is normal. We're waiting for what is this confusion? Then we hear riding a horse, describing a string that's not there. What do we do with that? And you can take the weakness out for now and just where in the brain would you put this, or what type of syndrome would you even call this, that the patient has all of their cognitive faculties intact, presumably the elemental attention, memory, and speech, and yet is clearly not interacting in a normal way with the environment if they are paraplegic and think they're riding a horse and can describe Ori's imaginary string. Amanda or Joy, any comments on the mental state here? I think you're muted.
Yeah.
Amanda.
Oh.
I just think about like infection and like, I don't know how to say in English, transversal myelitis.
Same word, yeah, transverse myelitis. Yep, same thing.
It's a great thought, but I don't know if the signs in the physical exam it's compatible with this disease, but there is an infection and cause the symptoms. I think that is, or Guillain-Barré, it's an option for me.
I see. Yeah, excellent. So if we took just the motor, yeah, this would all be fair game for Guillain-Barré, except that urinary retention, which you can get a little bit in severe cases, I've been told by the experts, but would definitely give you pause and make you want to evaluate the spine. And can, in some cases, affect the mental state, as in Maria's case of Bickerstaff from, I don't know, a year, 2 years, it all blends together. It was podcast at some point, but it was a long time ago. And right, and so you're wondering also, could this be transverse myelitis, which is possible? And that term is a little bit tricky because not all inflammatory myelitis is transverse, and not all transverse myelitis is inflammatory, can be infectious. Well, infections have some inflammation, of course, but that term is usually used to describe an inflammatory full thickness, axial full thickness myelopathy, but there are many causes of that syndrome, not all of which are primary inflammatory disorders, and disorders like MS that are primary inflammatory often are not fully transverse. So just to throw that out there. But yeah, spinal cord, I think, is still on the table here. We just have to wonder why after weeks of this going on, we're not seeing any upper motor neuron signs, though if you're getting the anterior horn cells, so if you don't have just a transverse lesion at one or a few levels, but a longitudinally full thickness lesion, so affecting sort of the whole cylindrical volume of the cord, you can get the lower motor neurons on the way out, and then that could be an explanation for putting all this together, and then you would sort of mask what would have been the long tract upper motor neuron signs by getting the lower motor neurons. I have to say, Ori said a word here that then set me off down a different path. I don't know if he was planting a trap for me to go down that path, or giving us and me a clue. But when you hear confabulation as part of the mental status, what does that make you think of?
Okay, so like I said, there should be some sort of problem here with the ascending reticular activating system as far as their alertness. I wouldn't, correct me if I'm wrong, but I wouldn't say they are alert. They're confabulating. They're not meaningfully engaging the external world. So I wouldn't label this as alert. They may be aware, yes, but they're not interacting correctly, meaningfully with the environment. But so confabulation, I would think the whole subcortical and I'm blanking some of the
Yeah.
anatomy here, but I'm definitely thinking here the definitely the dorsal prefrontal, the whole cognition part of our primary parts of our brain, that is the center for cognition and the whole and plus their activating system and their confabulating to like
Yeah.
the cortical part.
Yeah, very good. So right. So yeah, I think, yeah, it depends on your definition of alert, I guess. But I think what Ori is trying to tell us is that if you walked into the room, or sometimes the way I like to think of this, if I watched through the window, Ori talking to this patient without being able to hear what they're saying, I would think it looked normal, that they were having a normal conversation with normal back and forth. And if I didn't speak the language they were speaking, I would think that looks fine. And then until I hear the translation, no, the patient thinks they're riding a horse. Okay, that's not fine, but they're awake, alert, attentive, speech is normal in prosody, grammar, etc., but the content is very abnormal. So when I hear confabulation, I guess there are really two things. One is cortical blindness, so Anton syndrome, where patients are cortically blind.
Okay.
Their visual pathways work, but the occipital lobes aren't processing it, and they are anosagnotic or unaware of that blindness. So the patient will confabulate what they see and will continually, even though you can show that they can't see by, moving quickly towards their eyes, they don't blink. You can test that the visual pathway is, other aspects of the visual pathway are working because they will have normal pupillary reflexes if there's not some other pupillary abnormality affecting the pupils. And yet you ask them, what am I wearing today? Oh, it's a very nice suit, sir. Your suit looks very nice, even though you're wearing scrubs, or that sort of thing. So that's one. And then confabulation occurs in Wernicke-Korsakoff syndrome, right? So in Wernicke's encephalopathy, very classically, patients confabulate and tell all kinds of stories about what they're doing. And some might sound sort of, very improbable, like that they were riding a horse, even though they're paraplegic. But some patient will tell you, oh no, I was, this morning I was at work, and they would tell you things that would have normally happened if they were not in the hospital with Wernicke's syndrome. I was, I cleaned my house and I had this for breakfast, when, you can see that none of those things are true. Now we think of Wernicke's, you think of this triad, right, of eye movement abnormalities, encephalopathy, and cerebellar ataxia. But I forget the percent of patients who have the full triad, but it is pitifully low. One of these things we memorize for the USMLE, and then in real life realize, oops, not really true. And a lot of patients don't have one or more elements of the triad. And so this is a hard diagnosis to remember. I had a recent, remember to think about. I had a recent case, and I didn't realize it until we saw the imaging, because the patient had been intoxicated and was very confused for that reason, and couldn't move their eyes that well, and had some nystagmus. Didn't really have ataxia, but couldn't really participate well in the exam because they were confused. And I thought, well, whatever substance had been ingested probably is causing a little nystagmus, and I kind of threw it away. And then we thought, well, let's just get an MRI. The patient's not coming back to normal, and the MRI had classic findings of Wernicke's. I said, oh, it's confusion and eye movement abnormalities as Wernicke's. We associate this often with, well, the cause is thiamine deficiency, B1 deficiency, but can be associated on exams often with alcohol use, but can be from malnutrition, hyperemesis gravidarum, other causes. So if I was, again, I don't know if Ori was sending me a trick or a clue, but thiamine can also cause a neuropathy. This is the dry beriberi. Actually, I probably read this and memorized at some point, but didn't actually hear about it until one of the first times I listened to the CP Solvers podcast years ago, and heard Robbie discussing a case of weakness and brought this up, that it could be dry beriberi. And I thought, who is this internist that knows all of this neurology and has B1 deficiency on their differential for a rapidly progressive neuropathy? My goodness, who are these guys? I want to get to know them, and I'm very glad that I did. And that's why we're all sitting here this morning. So that could be one way to put this all together, is this patient thiamine deficient. If this is the cord and we put the urinary retention back in, then we have a brain cord syndrome. That confabulation is just so specific, I think, to one of those two problems. He didn't tell us about the pupils, or if there are other evidence that her vision works, but he's shaking his head. So the vision is okay. This is not Anton syndrome. Yeah. So if it's really confabulation, it's hard for me to pull away from Wernicke's because I can't really place a lesion otherwise to do that in isolation. Because usually patients, yeah, I guess you had some amnesia, you could put something along the Papes circuit. Yeah, so it's hard for me to pull away from that diagnosis. If this was brain and cord together, we could wonder, again, as we mentioned earlier, is there some, Amanda mentioned some underlying infection like endocarditis that's seeded an epidural abscess, compressing the cord, and then thrown some stuff upstairs and caused some small strokes. In a young child with this presentation, maybe you could worry about ADEM, acute disseminated encephalomyelitis, sort of post-infectious inflammatory syndrome with multifocal brain and cord lesions. But as I said, that confabulation is just sort of such a specific thing. I'm not sure it can localize outside of that circuit of Papes, and there aren't too many things that selectively do that and cause a neuropathy. So why doesn't she have eye movement abnormalities to complete the triad of Wernicke's? Well, some patients don't. And why doesn't she have ataxia? Well, she's too weak, as Ori said, to even evaluate for that. So that's sort of, at least by the buzzword Ori used, the place I'm having trouble peeling myself away from, and I don't know what to do with the urinary retention. But here we are. We might even have that hypothesis and say, oh, we might feel clever that this could all be thiamine deficiency, but thiamine level you can send will take weeks to come back. In the meantime, since that may be a clever but incorrect diagnosis, what tests, if you could each have one test, what tests would you order Joy and what tests would you order Amanda? And then we'll ask Ori what tests he did order.
Amanda, sure.
MRI,
Yeah, MRI of what? Yeah, what part do you want to get an MRI of?
all body.
The whole body?
No,
Yeah.
but I want to see the spinal cord. So the brain and the spinal cord.
Yeah, so I think we need a picture of the brain. I agree. Probably this patient arrived with a CT or an MRI that may have given Ori some information or not. The findings of Wernicke's can be subtle if that is what this is, and could be missed if someone's not looking for it. And an MRI of the whole spine also. Well, yeah, if we left the bedside saying, I don't have an explanation for that urinary retention, and it would be hard not to think about getting a picture of the spine. And if you could only get, so you can get a full spine protocol, Ori and I have talked about this, it's lower resolution and sort of more like a rule out cord compression type of, but if you really order a CT and L spine and brain, the patient sitting in the MRI for a long time, they're going to start moving, you're going to get poor quality study. So I definitely would get the brain, because we know something is going on up there. And then if the arms are involved here, we didn't really tease that apart, and we don't really have time that it's worse proximally. Maybe I am missing something important there, but I'm going to hopefully not for now. If the arms are involved, you could say, let's get brain and C, and we'll get a little bit of the top of the T spine, but you may realize that you have to send the patient back if you don't get an answer on those. Or you could do a brain and a full spine just to make sure there's no major compressive obvious lesion. And if you get nothing on all that, you may have to go back and get a particular part of the cord. So what were you thinking at this point, Ori, as far as what you thought was in the differential diagnosis, the localization, and what tests you wanted to get to try to take it over the finish line?
Okay. I'm going to give you a big set of data, and then there will only be like one more piece after this. Okay.
Okay. Thank you for.
Okay. Yeah, just thinking about time.
In 3 minutes. Yeah, we got it.
Okay. So when we got her MRI, she had an MRI brain and total spine. And the MRI brain showed susceptibility artifact in the mammillary bodies and some T2 flare hyperintensity around the periaqueductal gray, which was consistent with Wernicke's, or concerning for Wernicke's. And then we did an EMG, which showed an acute motor and sensory motor axonal neuropathy. With sparing of the proximal arm. There was no denervation of the proximal arm muscles. And then I think that there was maybe we can kind of, well, I guess, yeah, maybe we can stop there. and go from there. Yeah.
Okay. Amanda or Joy, are we finished or?
Oh, sorry. Can I tell you one more thing? She
Please.
had a tap at the outside hospital, which had a lot of protein and no cells.
Okay.
Yeah.
Are we done? More data?
So,
Yeah. I think I'm done.
Ori's done. Amanda or Joy, any more data you would want at this stage? The outside hospital has done a lot. Ori has done a little more.
so so I was thinking earlier, I would definitely do a MOCA here to rule out cortical, the whole cortical to explain the confusion here or the level of their awareness or mental status. But then we got this data regarding the MRI findings. Definitely leads us towards a subcortical, the circuit, the peak circuit you mentioned, Dr. Berkowitz earlier. So it's definitely that, maybe from malnutrition here, given the history. The axonal neuropathy of EMG makes me think towards, something systemic is going on here, and that also kind of like consistent with their MRI findings. If we're thinking Wernicke's here, and but definitely I would rule out the other stuff like the inflammatory stuff that we think here, and the infectious panel. So since I'm already ordered for us the brain MRI and this one.
Yeah, very good. So good for you for knowing the MRI findings in Wernicke's that affects along this medial structures, so the mammillary bodies, which can be enhancing or T2 hyperintense and or have hemorrhage in them, which is what we're seeing here with the susceptibility artifact. And then the periaqueductal gray in the midbrain, the sort of midline thalamic, hypothalamic structures. Again, as I mentioned, we made this sort of diagnosis in reverse by MRI recently, and by the MRI findings. And actually the patient presented very interestingly, was found down with hypothermia. And we learned that from the hypothalamic lesions in Wernicke's, you can actually get hypothermia. So these sort of midline structures, midline around and below the third ventricle, and then sort of mammillary bodies are midline, and then sort of midline dorsal, midbrain, all findings that were present in that patient and then in this patient. Now you might say, well, Wernicke's, it didn't explain the peripheral nerves, but thiamine deficiency can do this. And most, although not all, toxic and metabolic neuropathies, as Joy mentioned, are axonal. And disrupting axonal function. So they presumably saw low amplitudes with normal velocities and latencies here, and that tells us there's a motor neuropathy. Now, without what's going on in the brain, you could say, there's an acute motor and sensory axonal neuropathy. Well, if you just take the first letter of each of those, you get AMSAN, which is a Guillain-Barré variant, more common, I believe, in Asia, the axonal variant. And not so commonly seen here in the States. We usually see the demyelinating variant. So I would still be putting this all together as thiamine deficiency. I would still not be sure about the urinary retention, though I'm sure Ori will explain how that fits in. And then the other thing we're left explaining here is the high protein in the CSF. Again, if you take out the brain MRI and take out the confusion, and you could say high protein, an acute neuropathy, even without the EMG, I'm worried about Guillain-Barré, but I think we learned in this case, because the patient I mentioned who was found down hypothermic also received a lumbar puncture, had a very high protein. And at first we said, what do we do with that? And then learned in retrospect that you can see that in Wernicke's. So ever since you said confabulation, I couldn't move myself away from thiamine deficiency, though if I know Ori, he's got one more trick up his sleeve here.
No, I think that's great. I think that where we were at this point, and we could never explain the urinary stuff, so I don't have an answer for that. So we went on a bit of a side quest, just as an interesting side point in the -1 minute we have left, which was that there was maybe some report of like nausea and vomiting over months. So we actually, and the idea that we had was that maybe this was all thiamine deficiency, And it wasn't that there was a neuropathy that led to weakness, led to nutritional deficiency, which led to the Wernicke. So we actually got an EGD, which had normal, like normal mucosa, like no evidence of evidence for malabsorption. And then the interesting thing was that her weakness essentially progressed. So she was admitted for like weeks at this point, and eventually her deltoids actually and elbow flexion went away, and she became like fully plegic in the arms. And so maybe
While she's getting
so,
thiamine.
what?
While she is getting thiamine.
Correct. So the question was like, is this just like a coasting delayed phenomenon of the nutritional deficiency, or is there an ongoing like axonal pathology that's happening? And then so what we did is we got a nerve biopsy, which I will tell you what it showed in 1 second. Sorry.
Yeah. So do you want to just explain quickly coasting, because that may be a new term to folks, and that's an interesting pearl.
Yeah, so coasting is a phenomenon where, so for example, you can get a neuropathy with. I usually think about this more with like toxins or like chemotherapies, where you can be exposed to them and then have essentially, even after you've stopped the exposure, have a delayed progression or like persistent progression of the neuropathy, even after the like toxin is withdrawn.
Yeah, brilliant. Right. So yeah, chemotherapy neuropathy is sort of a quintessential example of this, right? So the patient has a neuropathy. We know it's from the chemotherapy. The course of chemotherapy ends, and the natural course over time will be for the neuropathy to get better in most, but not all patients. But often there's this coasting phenomenon where the neuropathy actually gets a little worse, continues to get worse after the inciting agent is withdrawn. That's called coasting for some reason, sort of continuing to coast along even after you turn off the gas of the car or whatever is causing this. So yeah, it's interesting. This would be sort of a reverse coasting. Rather than removing something and seeing it get worse, you've added the presumed treatment and not seeing it get better. And I don't know enough about, actually, I don't know anything really about dry beriberi B1 deficiency to know if you could see that. So you're wondering, does she have thiamine deficiency and something else causing a neuropathy and getting a nerve biopsy? And I guess the main thing you'd be looking for is whether there's some inflammation that would sort of lead you down a different path. I don't know if you can see inflammation in thiamine deficiency, but I'd imagine what you'd mostly see is loss of axons. And maybe if you saw that and you don't see a big influx of inflammatory cells in and around nerves or vessels related to the nerve, you might be able to reassure yourself that unfortunately this patient had a lot of axonal damage and you can replete their thiamine, but you might not grow back too many axons.
Okay, so I think so. There's no. I don't think that we didn't find evidence of coasting in beriberi, despite my efforts to look for it. And then I think just briefly, the other question was like whether there was an overlay of a critical illness myopathy. She had been intubated at this point for a couple weeks, and maybe that's why she was worsening. But the nerve, so we did a repeat EMG. We found a place where there was active denervation, and the nerve biopsy showed ongoing severe loss of large and small myelinated axons with perivascular and endoneurial inflammation. And so there was some inflammation there. And then a number of antibodies returned positive, or 2 antibodies returned positive on the neuropathy panel from WashU.
Oh my goodness. Okay, so you found inflammation. I don't know if that's fair game for thiamine deficiency.
No inflammation in thiamine deficiency in beriberi, apparently.
You did not find evidence. So you found that on the nerve biopsy, and you learned that you should not see that for thiamine deficiency. And then, wow, amazing clinical instincts to say, if this is all thiamine deficiency, presumably her, well, maybe or maybe not, her brain was getting better and her neuropathy was not. Could she have a couple things, or your interesting hypothesis that she has some underlying disorder causing a neuropathy that caused her to get so weak that she wasn't eating, that she became thiamine deficient, that she got Wernicke's, rather than being parsimonious and saying, this is all thiamine deficiency. Wow, that is an impressive leap to make. And now you found an inflammatory neuropathy, and it's been going on, keeps going on for weeks. So it's probably too subacute now for Guillain-Barré. So we're in sort of the CIDP sort of, and some CIDP patients will present relatively acutely and are thought to have Guillain-Barré, but they keep getting worse. So are we now in sort of that camp? And then you sent presumably paranodal antibodies and, well, yeah, okay. So,
Yeah.
so were these, I guess the question now is, are these antibodies relevant to the patient's clinical presentation? And you're going down a different path and now starting immunomodulatory therapy, or are you taking sort of with the bladder? Well, I guess you could see saying, well, maybe you could see a little inflammatory and beriberi. How many of these patients have been biopsied and these antibodies came back and I'm not sure what to do with them. So what antibodies were they?
Okay, they were anti-sulfatide antibody and then anti-FGFR3, which is associated with a sensory neuropathy. I don't know very much about these antibodies. Yeah, and to be fair, and they were drawn like several weeks after IVIG, but I guess they're rare enough that like maybe you wouldn't think that they would be false positives. But I can tell you where I don't have much more certainty to this case than where we are, except that she got a lot of immunomodulatory agents and has not gotten any better. So she essentially got a course of IVIG at the outside hospital when she initially presented, and then continued to get worse, and then she essentially was worsening for at least 8 weeks. So we treated her as we essentially got the nerve biopsy, and then we treated her as CIDP, and she got another round of IVIG. And then once we saw the inflammation and the antibodies, we pulsed her with steroids, or I had already rotated off service. She got pulsed, and overall is still plegic. Yeah. So not a great recovery, but I guess although like maybe like there's the axonal neuropathy was so severe that you weren't going to regenerate, and she doesn't have any more muscles proximally to have a neuropathy, like to become more weakened. So I feel like we kind of missed the boat a little bit on treating her early, but I think that we thought about her right in the sense that most parsimonious explanation would be a nutritional deficiency.
So what was the interpretation by you and other experts there of like, are these antibodies meaningful? Does she have two things going on here, or sort of ambiguous, but try treating her to give her a chance?
Initially was that, but then they spoke to Neuromuscular WashU, who felt very confident that the antibodies were meaningful and they're talking about like, or at least from the chart, it looks like they're talking about like Rituxan or Cytoxan. So they're thinking that this is actually that the thiamine deficiency and the Wernicke was secondary to the weakness and nutritional component. And the story was like a little bit of an odd story, but it sounds like she was like living alone and like really like bedbound by herself, eating like baby food for a long time. So it sounds like you could make there could have been a significant enough nutritional malnutrition that you could have gotten thiamine deficiency.
You mean to cause the whole thing, or
No. From she got
the original,
whatever inflammatory syndrome is going on, and then she became thiamine deficient.
Yeah, what a tough case. Well, yeah, amazing. I think leap there to say, well, this all fits a little too nicely into a package. Let's make sure we're not missing anything. She's not getting better with treatment. Although, as you said, we don't see too many of these very severe acute axonal neuropathies, but the few I've seen, the patients with demyelinating Guillain-Barré, as we've talked about before here, they look very impaired when they leave the hospital, even though you've given them plasma exchange or IVIG, and can actually have an extraordinary recovery. One of our residents in Boston ran into a patient who was intubated and a quadriparetic in the ICU, ran into the patient in Starbucks. Like a few months later, it can be pretty miraculous. Myelin just takes a long time to grow back. But yeah, if you lose the axons, they're gone, and those patients have a poor prognosis. I've never heard of the FGFR3. The sulfatide is some myelin antigen of some sort. But did they think that explains an axonal neuropathy? I don't know enough about it. Or
I think that there was they invoked that this was such a severe demyelinating process that we had lost axons already.
But your EMG, you didn't see slowing.
So the EMG, there was essentially like complete absence.
There was nothing.
There was nothing, and then there was give me 1 second. Anyway, there was some hint of like maybe increased F wave latency. Like there was some little flavor that you could imagine that there was such a severe demyelinating process that you have axon loss.
Wow. Okay. I see. Yeah, right. So if you have such severe nerve function that you can't even get nerve conduction on the nerve conduction study, right? Then you don't know if you obviously don't have axons conducting, but you don't know if you lost them because you first impaired all of your myelin and then secondarily lost all your axons because you can't conduct a signal to know if it's slowed or not. Wow. Okay. Well, all right. That is a very instructional case for many reasons. And I guess it'll be interesting to track and see if with some very aggressive immunomodulatory therapy, there's some hint that you're arresting this process and some myelin grows back along whatever axons are still there and you get some improvement. And then did the mental status improve with thiamine?
I mean, she was still confabulate. She's still like altered, and then the steroids didn't help. But sorry, I would say that there was like the one thing that did kind of improve was that she was essentially intubated initially for an aspiration and like hypoxemic respiratory failure, and then her neuromuscular weakness got worse, and she was unable to be extubated, and she got trached. And now they're talking about decannulating her, so maybe her respiratory muscle weakness is improving. So I mean, maybe I don't know. It's hard. It's hard. I feel unsatisfied, but I feel like there won't be a satisfying answer.
Yeah. Wow. Well, thank you for bringing this case. We learned a lot. I thought we were budgeting our time well, but it looked like thiamine deficiency, but I should have known that there would be some twist that
I told her there was a twist and a half. So
yeah, you tried to give me a clue, but I only saw twist and didn't get twist. I didn't pick up on the half. Not that I ever would have gotten to where you all got with thinking about this case. Fantastic. Well, thank you for everyone for sticking with us for this somewhat longer morning report. I hope you and your colleagues, Ori, are writing this case up because there is a lot to learn from it, even without a definitive answer. Make a nice clinical reasoning case because there's a lot of clinical reasoning to be had. And who was doing teaching points? Maria, Valeria, whoever is doing them, we'd love to hear about them.
Yeah, it was me. Oh, thank you so much, Ori and Aaron, for this case. It was an amazing discussion, as well as Amanda and Joy. So we started with the chief concerns of confusion and weakness. And on the confusion piece, we should first rule out toxic or metabolic causes of it, such as hypoglycemia or like a vitamin deficiency or electrolyte abnormalities. And then on the weakness part, we should identify the pattern of weakness to localize it on the corticospinal tract and prioritize multiple emergencies such as GDS, neuromuscular crisis such as myasthenia, and Cauda-Equina syndrome. And then on the differential for rapidly progressive quadriparesis, as this patient seemed to have, we should include etiologies that go from the spinal cord and then downwards, such as a myelopathy, a polyneuropathy, neuromuscular disorders, and a myopathy. And then search for clues that could localize even more on the neuro axis, such as if there's compromise of the bowel and bladder, that it was kind of the thing that made us doubt in this case, then back pain, contacts, and toxicities that this patient indeed had. And some pearls that we had on this case, there were a lot of pearls. But first, on the testing of confabulation, that we can use the non-existing string to assess it with the risk of looking a little foolish. And then the neck flexion and extension can be a proxy to examine the diaphragm compromise that I didn't know about. I usually use the counting for respiration. And then oxygen saturation is not a good proxy on diaphragm compromise, especially in patients with GBS, because saturation is not compromised, but CO2 retention, because the diaphragm is not working very well. And also, even though in this patient, it was kind of the thing, the red herring that made us question over and over again if this was indeed GBS. Urinary retention can be present in GBS in rare cases. However, we will always rule out spine compromise. And then on confabulation, very small differential, usually prioritizing Wernicke-Korsakoff, and also other rare causes such as dry beriberi and Anton syndrome. And on the Wernicke's MRI findings, which are considered T2 hyperintensities in the mammillary bodies, dorsal thalamus, and these kind of deep structures. And also on on coasting, that I also didn't know about, a new term, on the progression of symptoms of neuropathy after exposure of toxins are removed. So thank you so much for this amazing case.
Thank you very much, Valeria. Excellent synthesis, and thanks for flying through it so quickly, since we're now well over, as is our tradition in Neurology Morning Report, especially when we get a case like this from Ori. So thanks for bringing the case, Ori. Thank you, Joy and Amanda, for the excellent discussion, and Valeria for tracking all the teaching points. Great to see everyone. Happy holidays, Happy New Year, and we will see you again sometime in January. Take care, everyone. Have a great day.